Welcome to Inspiring Heartfelt Conversations presented by Anonymous COCOON, in which we explore a range of end-of-life topics with noted professionals. My name is Barbara Morningstar. Today, my guest is Carolyn Saunders, and we will be exploring the amazing and important role of the palliative care nurse. Carolyn has been nursing for just over 10 years, 7 of which have been in palliative care. She lives in the Vancouver area in British Columbia, and we first met about 10 years ago when she was working as a nurse on the palliative care unit in the hospital. So welcome.
Thanks, Barb.
It is
lovely to see.
It is so special to be able to do this. It's always, I love all the guests I get to bring on, but when I get to bring on someone I know and a colleague who we've worked together on, my heart's kind of invested in knowing you in a different way because we've been around the patients and families and have cherished memories of those moments together, right? So I want to start by asking you actually how you came to be a palliative nurse. How did the whole orchestration of life bring you to that moment?
I always say to everyone that palliative chooses you, you don't choose palliative. Mm-hmm. Children are my kryptonite. And so when I was in nursing school, I was a late to life nurse, and I did a rotation in peds, and I knew I couldn't do peds. And I did a rotation in maternity, which did not work for me. It felt very barbaric. And I had a very dear friend, I call her my adoptive mother, who actually was on the unit that I worked for, the palliative unit, when I was finishing up my nursing degree. And palliative chose me. I knew I could be there. Actually, I knew I could be of best service there. And I sort of fell in love with palliative. How's that?
Well, companioning the family member on the unit.
Yeah, I think it was seeing how in a vulnerable state, you could still give relief, you could give compassion, you could walk with someone. And so having that experience on the unit and then reflecting on, medicine wards or surgical wards or other places. I actually started out the very beginning of my career, I was on a medical ward, a very tough medical ward. And then I moved into palliative. So I was about 8 months on a medical ward, which was good because it solidified my career, consolidated my practice a bit. And it allowed me to know what normal looked like and then to translate that into palliative. The piece that's different for me about palliative was that there was that emotional link, and it was very different, where you're on a different part of someone's journey, their health journey, if you want to call it that. And the trajectory is not curative. And so when you're working in non-curative medicine, that's what I have termed it, you're dealing with a different set of standards. You don't want someone to get better, but you want them to live better.
Beautiful. Okay, so let's step back a little bit, because it's always interesting to hear the loss history or the exposure of death for people before they actually come to this place in their life. So what was your first experience with death in your childhood?
So I really had to reflect on that because I was raised in United Church home. My dad was a minister, and we went to funerals all the time. That was just sort of part of our family of origin upbringing. But there was one little boy in particular who had been unfortunately murdered by his father, and it was one of my best friend's cousins. And I remember that process. I remember, being at the church. I remember the body being at the church. And I remember being around that death aspect of someone young that was within my peer group and being really shaken by it. I always had a very healthy or maybe unhealthy fear of death. But, and seeing it up close, I had a lot of exposure to death, and it was oddly normalized. But when I grew a little bit older, in my early 20s, I lost a very dear friend to the AIDS epidemic. And he actually was one of my best friends. And that changed me forever, because it started a chain of events very young where I was determined to live my best life, whatever that looked like. And it became sort of my mantra, if you want to say, best life. It's interesting because my kids are young adults now, and they term best life all the time. And that exposure to death young meant that I was going to live a very full life, regardless of how much time I had.
And what was it in particular about this friend and the couple who had died of AIDS that really kind of impacted you to even celebrate that theme more?
So that was, I was raised in kind of a small town, Ontario. And this was a gay couple, and they lived a big life, huge life. And I always say they raised me. They were 6, 7 years older than me. And they just had this joie de vivre that I had never experienced before. And it was just this embracing of life, making life larger. Even what would be sort of mundane tasks became larger than life. And I always say that I was raised by gay parents, right? Because they just, it was really a crux of my life, 16 till the time I was 21, almost 22. And this couple, we just did sort of these magical things, dinner parties. And, Chris, the gentleman that passed away, he used to say, he just didn't need one day to have pride, that he had pride in his life all the time, right? Mm. And it's a great way to live. And as a young woman, you sort of learn this larger than life living. And when he passed away, it still is a huge hole. Actually, yesterday it will be 31 years that he passed away. So kind of fitting that I'm doing this today, Barb, with you.
Mm. Oh, that's a beautiful gift to bring into the work, right? So
100%. And it makes you mindful of, mundane becoming absolutely special, not only in working with palliative patients, but also in my own life.
Mm-hmm. Well, that bridges beautifully. You started to explain the difference of palliative versus sort of how you experienced other medical wards, but can you elaborate for the audience? Can you explain the role of the palliative care nurse so they understand it a little bit more intimately?
So I think the best way to say it is the way I try to frame it for families is, we never know, no one knows how long we have on this earth. It's an unknown. It's the magic of it. And it's learning to live whatever your best life is in that moment. So, for instance, at the bedside, I always start by saying, what is it you want to do today? And often people are a little bit puzzled by that. And it's like, what would your best life look like today? So for some people, that's getting up and walking. For some people, that's, seeing their families. It is all meeting people where they're at. So a great example is one time on the ward, we had a patient that wanted to see her daughter get married. Her daughter wasn't engaged. Her daughter had a brand new boyfriend. And so this was obviously an impossible best life moment, or seemingly impossible. So what we decided to do was we contacted I called different bridal shops and found a bridal shop that would have her and her daughter and her husband go, and the daughter tried on different dresses. And then they took bridal photos of her sort of wedding morning. And, that's best life. That's living best life. And by embracing that, you get a sense that everything is possible in life. And we're not limited by how much time we have then. The difference between curative medicine and palliative medicine, for me, from a nursing perspective, is the fact figuring out how to get someone to that best life, regardless of whatever symptoms they have. For instance, managing pain, managing nausea, vomiting, managing mobility, managing, whatever that issue is, let's find a way to manage it. And the palliative drug box, I always call it the toolkit, the drug kit. You can create this little magic box where you can use drugs so that you can give best life, whatever, again, that might be. And I have had the great fortune of working with teams that really understood that. And for me, once I framed everything into that sort of best life, it takes the focus off dying, even if it's just for a split second. I had a cancer patient one day said, I want a day off from cancer. And I want a day off from dying. And, you know, that's the other piece for me, is like giving someone that day off from dying, even if it's just a very small portion of that day, allowing them to live fully in whatever task it is they deem important. And the other piece is what I feel is important really doesn't matter at that point. My medical expertise is to look at signs and symptoms that I know fit into a box, but what the patient brings to me is how those signs and symptoms fit into their lives or what is significant to them. And often they don't meet, but my job as a professional is to have boundaries, but also to allow myself enough knowledge that I don't know what is the best for that person always. I know medically maybe what the best set of rules would be, or what the best tools from this little toolkit would be, but I don't always know how that impacts the person.
So a deeper inquiry into that.
Yeah, a curiosity, and a true curiosity, because the other piece for me is having that genuine spirit. And I also believe, you know, the boundaries piece is very important, because through my licensing, so in British Columbia, our licensing body actually has a boundaries course that I do on a regular basis. And it reminds me where I stop and the other person starts. But for me, there's an intimacy between a palliative nurse and a palliative patient. And that intimacy is interwoven with vulnerability. And so I do share part of my life, but I am always very mindful of that professional boundary. So for instance, recently my youngest moved out, and a lot of my palliative clients know that, because when I go to their houses, now I'm an at-home palliative nurse. You know, it's not just about the visit or whatever symptom, it's about the intermingling of professional, personal relationship. So often they start by asking me, oh, how did the move go? How are you doing? How's this? And it enables me a bridge to get through some of the giving them a day off from their disease load, or giving them moments off from their disease load, and then the ability to intertwine what their best life would look like. And it allows me to be vulnerable enough that they can see that they can be vulnerable with me back. It's that exchange that I really, that's the dance, or that's the magic for palliative with me.
That is
because
beautiful.
I'm meeting someone at the most vulnerable part of their life, right? I am not meeting them in a professional capacity per se. You know, I've dealt with executives, I've dealt with CEOs, I've dealt with truck drivers. I'm not meeting them in a professional capacity. I am meeting them in a vulnerable capacity where I'm the expert, which I don't believe, because I still believe they're the expert of their own life.
That's lovely. So let's just touch in on too, you as the human being in the caregiving role, with the added demand of COVID right now. How have you coped with the added challenges of COVID? Because we know it's put added pressure on some of the frontline workers, clearly in ICU, but you're normally around death and dying. But for you and your role, how have you coped with the added challenges of COVID?
I think first, Barb, the added challenges are the important part. As a palliative nurse, what I hold in high esteem is good death. You know, giving someone the best quality death possible. And I think that a lot of us in this line of work have talked about the fact that what we've experienced are some people not having the best death possible. And that is heartbreaking for us. COVID added an extra stress because people could no longer access hospices the way they would, even hospitals the way they would. So people were coming out to die in the community where, best death didn't always look the same. And that in itself was, it was very, very difficult to cope with. That being said, I have to say that I relied on my peers. And Zoom was a great tool. That was a really great tool for a lot of us to, get together and discuss or commiserate or just, rely on each other for support. This kind of work, it fills you up as much as it drains you. People always think of palliative as being an excruciatingly hard, or even other nurses, they're like, oh, I couldn't do that. But I relate it always to palliative chooses us, right? We don't choose palliative. And so for us, if we rely on each other sort of for that support, that's how we get through things like global pandemics or like shortages in actual nursing bodies. I mean, that was the other hard thing, is that I have had colleagues that have had COVID and, were just out of the workforce, taking care of themselves. I did rely a lot on nature. I mean, I am very blessed to live in one of the most beautiful parts of the world. Yeah, we are. And
we are so blessed. Like, who gets to live in BC, right?
You're right. So there were times where I would, take my lunch and go to a local park and literally just sit out in the middle of a field by myself and really reflect on why it was that this was happening, right? And try to have a connection to nature, because that was a constant during COVID. My colleagues, unfortunately, weren't always a constant, and we were all exhausted, right? I mean, that's the truth. Even now, I feel like I have a little bit of PTSD from the whole thing. It's just this feeling like, people are starting to go back to hospices now. And I am so grateful for the hospices that, are available to people. But I still am having these, it's kind of waves of surreal feeling that we're not really out of COVID and that it's going to happen again, right? But I have to say, I have to thank Zoom as a platform. It really saved my life, connecting with, fellow workers and just other people in my community, right?
And we've even had, in the past, we had support groups that we had to stop together where we chatted, and then we were doing it in person and we had to stop. So we're aiming to do that again.
I'm grateful for that.
In-person part's always a little more dynamic than Zoom, right? So
one of the problems is I'm a hugger.
You are.
So even with clients,
Me too.
This was another. This was an issue because I'd be sitting with I have a family in mind, and the daughter and the mother were both huggers, and so to not access physical touch, even with my own clients, that was absolutely gutting for me. And to have full PPE on. So full gloves, full gowns, full mask, and to be in that intimate dance with someone and to want to hold their hand or to be holding their hand, that touch, that therapeutic touch just means so much, right? And it really made me grieve that loss. But also it makes me now, as we start opening up from COVID, I am just so grateful that I will be able to do that again, right?
Yeah, enhancing the things that potentially we took for granted that now become even 100%. More enlivened, right?
Yeah, 100%. That is it. COVID actually gave me a lot of gratitude, which I know maybe sounds odd, but it gave me a lot of gratitude for, it tightened my circle, it tightened my support circle, and it also how I spent my extra energy. Yeah.
Okay. Well, and you've just beautifully elaborated on elements of self-care like nature and connection in whatever way that you can get, that you deepened in the COVID experience, right? So
Yeah.
So you touched on team, and I do have a question about that. I actually recently looked at a documentary from the foundational period of palliative care where they highlighted the collaboration of team and the multidisciplinary elements of it. So how do you collaborate with other team members, and what does that look like in palliative care?
So that's a really good question. And that's something that I had an extraordinary experience with my first introduction to palliative care. I came from, I had the great fortune of working at Surrey Memorial on North 52, which is, they do symptom management for people in palliation. And, the doctors there, bar none, amazing. And not, yeah. And the thing is that, my very first introduction was to a doctor who's no longer there, but his name is Aleko Alexiadis. And
we love Aleko.
Yeah, we do. Yeah, we do.
He'll watch this. We're going to put a big heart for Aleko. He's passionate. We love him.
Aleko set the bar very high for me at the very beginning. One of the first times I met him on the unit, he said, "You may see 1,000 deaths, but this is this person's first time dying." And that set a bar for me because, and I teach that. I always teach that when I'm training anyone in palliative, ever in nursing, because I think it's really important to realize that, is that it doesn't matter how many deaths I see, or how many, good deaths I see. This is this person's first time going through it. So by having that sort of first tier set that bar for me, it meant that everything sort of filtered down. Then I had the great, amazing fortune of working with doctors like Dr. Shika Minhouse, Dr. Shalini Nair. And, those are, professionals that chose to teach. So they chose to teach nurses. Whenever we would get a symptom that was new or different, or a drug that we were using, because one of the things about palliative is sometimes in this toolkit, we use drugs differently than other places. And these are doctors that took the time to actually teach rather than just write an order. And so then that gives you the next layer, so then you're from the top down, you're starting to build your team, and it's building mutual respect. The other thing that I always remembered is that, our unit clerk was the person that was placing the orders, and again, I worked with one of the best unit clerks I've ever worked with, right? And so, yeah, Layla, like it's just, and then my colleagues were people that I respected. I worked with these nurses that had the same passion that I did. So when you have that as your very first experience, and I was a baby nurse at this time, I've got all this life experience. I'm a 45-year-old woman going into nursing from a business background. And I go into this structure where there's no longer really a hierarchy. It becomes sort of that, the model that you're talking about, where we work like a team. What my struggle has been is that because when you have that as your first model, when you move around in nursing, sometimes you don't find that model, and you always crave to recreate that. And so one of the things, now we have a spiritual practitioner in, we've always had a spiritual practitioner, but I found that they were being underutilized within the community setting from my perspective. And I look at where my client is at, because now we no longer call them patients when they're in the community, they're a client. And I look at the whole picture, because what my first teaching was from the my first experience in palliative was that there is going to be multifaceted ways to deal with this person's dis-ease, right? That whole uneasiness with dying. And so now I look at how many different team members can I have help me with this client. And I think that, when I go back to that very first model and keep it really simple, like Aleko's first model, it's like, I may see 1,000 deaths, but this is this person's first time dying. Then the care becomes centered on that person and that individual, which gives us individual care within a model that, often is we use the same drug for this, we use the same drug for that. It's true. we have sort of this cookie cutter idea because we see a symptom and we know how to manage it, but the symptom for that person is very individual. Yeah, maybe I'm an idealist, but I really feel that if the model is more of this, which is, where there is no hierarchy, and because that was my first model, I believe that the delivery of palliative care could be, amazing. And the experience of death could be taken from this very fearful thing into more of a celebrated thing, similar to birth, right? And that's sort of what I always work toward. I have this palliative fantasy, I always call it. And I'd like to see a center for palliative, multiple centers for palliative, where we employ nurses, doctors, physios, dietitians, everything under one roof, so that a person could go and get respite, from their disease, and then have this team manage them, and then come out and live their life however they need to.
Well, and in the template at the Royal Victoria Hospital in Montreal, all of those players were involved. There are access to social workers and spiritual care and volunteers. So how did you collaborate, or do you collaborate and weave those people in when needed?
So that it's harder in the community for sure, but I do access. We do a team rounds every week, and I'm a person that I know what I don't know. But there's usually an expert that knows how to do it. It's usually someone else's job if I don't know how to do it. And so for me, I try to get to know the person who is on my team that does that job, and then direct that person. It was easier on the unit because it was a closed unit. It was a 10-bed closed unit. It is still a 10-bed closed unit. And the volunteers were amazing. There's a service that the volunteers did that, may never have seemed very significant to anyone else, but it was huge significance. Actually, two. One was a tea trolley. And when my adoptive mom was on, as I call her, was on that unit, I remember the tea trolley coming around and receiving that gift of tea, that normal gift of tea at bedside. Role reversal, when I'm now the professional, I can see how directing those volunteers towards the rooms that could really use the cup of tea, that normalcy, is so therapeutic. We had another great volunteer. I mean, we have, all the volunteers were very special, but this one woman in particular, and she used to always give foot rubs. And that was kind of her thing. She would ask permission, and people would love the foot rubs. And it was so therapeutic. She was a very, I don't like the word unassuming, just a very gentle soul. But the therapeutic value of touch and of that soft nature was incredible. And that's something, it's a form of intimacy that I could never manage because of the role professionally that I had. And for me, it's not having an ego about being an RN, because the other piece is, throughout all my practice, I have learned some of the best tricks from care aides. I have learned some of the best tricks from cleaners. Everybody can teach me something every day. I have a friend, mentor, and, years ago in business, and he was an incredible teacher on how he knew how to do every single role in his company. And so at any time he could jump in and partake in whatever thing needed help. And that's actually how I always felt in the palliative unit. In the community, it's a bit different because you're accessing someone in their home. And so now you're going into someone's personal space and providing a service. And for me, I like to be very careful with my boundaries in someone's home, because that's very intimate. When they enter the unit, they're entering more of that clinical setting where the boundaries are, they're a little bit more, there's a structure there. When you enter into someone's home, especially when they're vulnerable, it's just you constantly as a professional have to maintain the boundaries.
Right.
So inviting other people into the home is much trickier because you have to access permission. So for instance, I usually do always express that we have a spiritual clinician and that they're non-denominational, because pain in palliative or any symptom management is multi-layered. So for instance, we talk about total pain, which is spiritual, emotional, and physical. So you could have spiritual pain and it could be manifesting itself in a physical way. You could have emotional pain and it could be manifesting itself. So because they're all intertwined, I just don't think that one way of cope or dealing with it, for instance, giving narcotic, may always be just that. You know, it's not that simple, right? Because if it was, we would just give the narcotic and people would feel better. And often what you see is people, you know, really struggling with spiritual and emotional pain, and it's intertwined. The physical is just the easy marker for it.
Well, and as you said, I mean, in the community we're talking about, there was home care, the unit you're talking about, and a 20-bed hospice residence that we were interacting with. And at one point I had the volunteer, we made up little I had little spa baskets with bows on it. Yes. And lotions, and they would go around, we'd call them spa baskets, and they'd give hand and foot massages. So when the nurses were struggling, they could send the volunteer in, and within just like 10, 15 minutes, that struggling patient with that soothing foot massage or hand massage that you said, you know, they fell asleep. Or I had a woman who had a little harp, and she would go around and play the harp on the bed, you know, and or just music therapy in general. One of the counselors on my staff was a music therapist, and I would watch some of the amazing stuff she would do with families and children, right? So I love that you're highlighting that, because all the disciplines bring different pieces, and as you said, it's not just the medication. We're layered as human beings, and all those disciplines bring in different components collectively that help to address the beauty of the dimension of that individual, right? So.
My downfall as a nurse is that in the community, I'm not task oriented. Because I have seen palliative done at such a level that my model is, fortunately or unfortunately, probably fortunately for my clients, maybe not, you know, as fortunate for my employer, is that I can't just go in and do a task and leave, because I realize that the therapeutic value of taking an extra 10 minutes will pay off 10 times more down the road. Because in order for me to make a suggestion to someone, you know, they have to trust me in order to accept that suggestion, and they have to see the therapeutic value for themselves, not just therapeutic value for a whole. And equally goes with the family. I have clients that have very small children, and entering into a home to do something that is an intervention, for instance, you know, any multiple interventions, you know, sometimes I appear every day in that home. So partnering with their child or their spouse is just as important as, you know, being with them or doing the task. The task may be a 10-minute task, but the entire visit may be a 30-minute visit, because I don't feel that it's best practice to go in, force myself into the home, do the task, and then leave right away. I do want some therapeutic exchange, because next week I may have to go in and be with that family while their loved one is taking their last breaths.
So, and bridging to that, can you share ways that you've helped families celebrate their last moments of life and wishes?
Yeah. You know, I have been really fortunate. I have a box of, it's gratitude. I just call it my box of gratitude, people that have written me letters or whatnot. And I have been so fortunate in people I've met. One of my clients was a English teacher and had spent their life work writing a historical book. And after they died, their child brought me a copy of that book. inscribed by that patient. And that patient and I, my first degree was in English, and I love romantic poets. And so, every day I had photocopied a piece of poetry for this person and then let them teach me about the poetry. And so I would write my notations down and leave it off my night shift. And then when I come back, they would write in the margins, corrections or, just ways of explaining romantic poetry. And, Tennyson or, you name it, right? Rossetti. It was brilliant. And accepting this gift, even though nurses are, we don't really accept gifts, keeping this book of history is very, very important. I have been to different things. One of the families used to have, pre-COVID, they had a golf tournament to raise money for a young father. And so I would attend part of that because I think it's important, especially when there's children involved. You have very intimate ties. One of the families still, I have a really strict rule. I don't connect with families. I always say that if 1 year after the passing, they can get hold of me through my place of employment. So I've had a few people that have actually accessed that have memorials, yearly memorials set up. And so 1 year after their loved one's passing, one person in particular looked me up and said, we're doing this memorial every year and we'd like you just to come and celebrate. And that was pretty amazing. I've been to many fundraisers which have benefited cancer. And in the name of that client, right? Which is really lovely. I usually, when I was on the palliative unit, it was a little bit easier because it's a bit more contained. We actually helped one of the young parents video themselves, do a video diary for young children. And so now, it's been almost 5 years, I think, that they've passed, but their children have a regular video diary that we helped create. We also had this phenomenal patient, a very young gentleman, and he and his brother wanted memorial tattoos. And so the unit, a bunch of us helped arrange a tattoo artist to come in and do a tattoo on the patient, the patient and their sibling. So both have memorial tattoos. Again, another phenomenal and really mind-blowing to me that could be facilitated. It's about the creativity. And it's interesting because I do not have contact with that family, but I do have contact with that tattoo artist. And once a year, around that time, I usually stop into his shop and we both, kind of have this moment because that young person, never wanted to be forgotten. And that's the kind of stuff that I think that finding people, helping people with creative ways. I've also been the recipient of a lot of wildflowers. A lot of times people would come back after memorial services and drop things off at the unit for the nurses. And, people would bring packets of wildflowers, which I've planted, right? And just so that they keep reseeding each other. I think that the interesting part for me is that there's been such creative ways that people have, marked their loved ones. I remember on the unit at Christmas, I often would take Christmas Day or Christmas Eve as a shift. I would swap it out because I knew that if this was this person's last Christmas, it was very special, right? And my family was fine celebrating on a different day, especially as my kids got older. But I remember this one family, their loved one had passed away, way 10 years earlier. And they always brought treats. They always brought a huge platter of cookie for nurses and for the patients on the unit, always on Christmas Eve. And that to me was a really, what an incredible way to celebrate, right?
Well, and we're hearing more too within that realm of creativity, people talking more about the importance of aesthetics, but the senses, to include the senses in different ways, hearing, touch, taste. How You've already touched on the beauty of that creative expression and invitation. Can you think of other ways you've had the senses come in to help to engage or highlight the experience even more?
Well, do you mean for the patient?
For the patient, yeah, because it's
so the
their
patient,
body they're experiencing it
right
through, right?
So we've had, massage therapists come onto the unit who have practitioners. We've had musicians come on that had a very young patient one time who was part of a band and was what they thought was in coma. And the band came in and played. And I sang because they were playing some of my favorite music. So we just sort of all jammed together with the family. And later, when the patient came out of this sort of coma state, he recalled it, which was really interesting. He knew exactly what was happening during it, which is always interesting because we always say at bedside, whatever you say, know that that person can hear you. So we I always encourage music at the bedside or prayers. I also had the great privilege of working with many, many diverse populations. And so I would always encourage, spiritual prayers or, different kinds of music, that sort of thing. We also used a lot of sense. Like if someone had something that was very dear to them, we would say to people, wear that perfume if you need to, right? Bring that thing back. Yeah, working in a closed environment is very, very, it's a privilege, right? Because you get to help people honor what's important to them. I had one patient that had done El Camino, the spiritual walk, and this person actually was a practitioner with palliative caregivers and had done a lot of work with palliative caregivers, but had gotten stuck in their own spiritual journey towards end of life. And they were on the unit, and for the first week they weren't my patient, so I thought, I'm not stepping in because they're not my patient. But the next week they were my patient, and I thought, okay, enough is enough. This is ridiculous, right? This person has devoted their life's work to helping others navigate this spiritual time. So I said to them, I want to know what's important to you. And their daughter was at bedside, and they said, they were really just very standoffish. And I said, there must be something in your home, something that you have put on an altar or put on something somewhere special. And the daughter said, oh, I know what it is, a picture of El Camino. So at the very end of El Camino, a lot of people throw their shoes over and went to signify the end of the journey. And so this person had thrown their shoes over at dawn and then had caught a picture of it, and it was absolutely magnificent. So I sent the daughter home to get the picture, and we rearranged the pictures in the bedroom, took down the standard picture in the palliative unit, and put up this person's picture of the end of the El Camino. And it was there for their entire time on the unit. And it was really amazing because it was very inspiring. And that prompted this person then to ask for other things that were of significant importance to them, little vase and, different things like that, little things, pictures, things like that. The other thing I always encourage families to do, and that person, is to bring a picture of the person when they were at their perceived best. Because I think it's really easy for practitioners to forget that these people have had full lives, and what we're seeing them at is a very vulnerable part of their life, and maybe not a part that they're, as proud of themselves. For instance, people have, become very gaunt at the end, or, have lost their hair or muscle mass. And I think it's nice to reflect and to remind ourselves that we are taking care of someone that had a very vibrant, rich life outside of this moment, right? When I'm within the home now, I try to do the same. I always ask people about their best vacation. And often I say, tell me about your best vacation ever. And I always get this crazy range of places, of things that people have done. The other thing that I use as a tactic, especially if it's someone that I can't make any therapeutic headway with, is I ask them where they want to go. So I had one client, and he had young adolescent daughters, or I guess, they were in their 20s when he passed. And we planned a trip together. And he had wanted to go to a part in the Philippines called Boracay, and it's where the beaches are the most beautiful. And so every day we would talk about the trip to Boracay, So I'd say, well, tell me what we're going to do on this trip. And then he would tell me about whatever water sport or whatever. And then one day his daughter showed up and she had all these postcards from Boracay. And she said, my dad told me that I need to put these all up. And so we filled the side of, with pictures of somewhere that it was obvious he could never go, right? But it was that keeping that dream or that hope or that just even allowing ourselves to escape out of. And it's interesting because that person's, one of that person's children became a nurse. And I had the distinct pleasure of watching that, young nurse grow up in, nursing life. And it's been an honor to work, at different points with them.
Well, it just shows the impact on her, like your first exposure to palliative, about how now her life journey has been called through that tender experience too. The image of the walk in the picture is really metaphoric of the end of a journey of life too. That's beautiful. Yeah. So the caregiver, we've talked a lot about patients, we've touched on the families, but what has working with family caregivers taught you about life and love?
Well, it's, I'm actually getting emotional. It's taught me never to take it for granted. And going back to my first experience being at the bedside, with, so I am very fortunate that when I moved to BC, I met a couple. When I was a very young mom at the time, and I met this couple through an organization I belonged to, and they kind of adopted me. And this woman, who I call my adoptive mom, Eileen, was one of the kindest women you'd ever meet. And so to sit at bedside while she was dying, I was in I called it a tsunami of emotion, because I felt like we would get information. She passed within 6 weeks of her diagnosis, of her official diagnosis, and we would just get information, and then there'd be another wave of information. And I never felt like I could get up for air. I never felt like I could quite grasp what was going on. So we were moved from, ER to oncology, and then oncology to palliative, all within a very short amount of time. And then next thing I know, she's telling me she wants to go to hospice because she doesn't want to come home, and she doesn't want us to have to look after her. And, again, tsunami of emotions. This set the stage for me, or it gave me sort of that behind the veil look at caregiver in a palliative role. So then I graduated and came back to it as professional. And I realized that a lot of times the caregivers, they are not professionals. Majority of them are not trained to be palliative nurses. What I always tell them is, I have like a speech, right? So if I've ever looked after your family, you've heard this before. So I always tell the family the same thing. It's like when you're on a plane and the oxygen mask comes down. If you don't put it on yourself first, you can't be any good to anyone. And then I teach about there's a diagnosis called caregiver role strain. It's actually a medical diagnosis. It's when the caregiver spends so much time taking care of their loved one that they get physically sick. And, that is really important information. The third thing I always say is that what you are doing is Herculean, because nurses get 12 hours off. So a nurse does a shift, and then we go home for 12 hours to recoup ourselves. What families doing at bedside or in the home, even more important when we're in a client's home, is that they're doing this 24/7, 24/7, 24/7. They may get a small amount of respite, but 9 times out of 10, that respite is to run out and get medication. And so that's the crux of what I try to teach when caregiver, is that bearing witness to someone, holding space for someone at this juncture of life is an incredible thing in itself. The fact that you're there to hold space for someone, whether you're advocating for them, whether you're helping them recount their life, whether you're just being present with them, that in itself is a huge gift. And that's the piece that is really important for me to parlay to families, not just for families, but also for patients or for clients. One of the things that's a really common theme for me is that we see that the other thing is I always tell a client when I first start working with them is my license is for them. If their family benefits from it, that's great. But by law, my license is for them to advocate and to work with them. And so I always ask them what is most important to them. 9 times out of 10 is they want their family protected. They don't want to become a burden to the family. So then when I'm doing advanced care planning, when I'm trying to understand and trying to meet someone where they're at, it's what are your wishes? A lot of people say, when I become too much of a burden on my family, I want to access hospice or I want to go to the hospital. I always ask where someone wants to die and what that'll look like. And a lot of times families are in shock when I say that. But most times the client or the patient are waiting to tell somebody. And they're waiting to tell somebody who has no emotional tie to the outcome. And so it actually makes them feel better. It's so incredible. And a lot of times people say to me afterwards, you're the first person to ask me that, or I'm really grateful that I got to talk about that. Does it mean I'm an amazing nurse? No, it means that I've tapped into some little formula, or I've been able to be quiet long enough, or whatever it is, to figure out that these people need somewhere to talk about this. And once I sort of understand where they're at, I don't want to be a burden to my family. If you see a caregiver starting to burn out, and this is probably the place where we should seek a hospice, or this is a place where we should get better respite, because I have already asked the patient what their wishes are, I can with clear conscience say, your dad, your husband did not want to be a burden to you. And sometimes people are holding on to life, not dying, even though they want to die, even though their bodies are done, because they don't want their loved ones to suffer at all. So sometimes you see when people transfer to hospice, they don't last very long because they can actually relax, because they can watch their loved one relax. It's a very interesting interplay. And the other thing is knowing where people are at and helping the families to accomplish what they feel their loved ones' wishes are.
Well, and even let's also touch in on the element of the patient feeling like they're a burden, but when you actually turn to the caregiver and the family, they don't want to see them go. So they're not actually feeling that they are a burden. It's the patient concerned about that, but the family going, you're not a burden to me. I love you deeply, and I can't imagine you not being here. So yes, how can we make this easier on all of us? But there's a gift in me loving you. I'm thinking about this with my husband. This was not an easy death, but I also know for me, it was an amazing opportunity to know an unconditional love and have moments with somebody in an intimacy that I had not known before. So that's an interesting art too, to work with the concerns of the patient, but honor what the caregiver is experiencing in that engagement too, right?
And for me, Barb, it's also, I remember a time with Eileen where it was more selfish for me to ask her to stay and suffer. It was more painful for me to watch her suffer than it was to just let her go, to love her and let her go. And having that experience also changed me, Because then I'm able to say to people from my own experience that it was, me wanting her to stay and suffer was far worse than me letting her go.
So what you're saying in that, just so we can help the audience, that you're coming to the end of life, they're imminently dying, and it's giving them permission. It's okay
100%.
if you go just in your conversation, even if there's no spoken word from the patient.
And you know what's interesting is that in phrasing, one of my colleagues, a really brilliant nurse, his name is Inder Gandham, he still is a palliative nurse. And, he said, he never uses the term, it's okay to go. Mm. He always says, let's tell them how we're going to honor them. Because the truth is that it's not okay that someone's dying, especially when you're talking to a young family, right? It's not okay. But you can say, I can let you go now and be at peace. And I think that that's the other piece of the art of palliative nursing, right? Of any nursing, is helping people to understand where they're at and helping families understand where the patient or the client is at. It's not okay per se for suffering, but I always say that if you can help someone have a good death, you can live with that and have no regrets.
Well, I remember how amazing the palliative nurses were when my husband they had to bring in palliative sedation at the end because of the extreme pain challenges. And so he was sedated for about a week before he died. But I remember we could tell he was turning. And here's a last wish. I loved holding his hand. I loved feeling his hand on mine. And I couldn't get into bed with him. I wanted to fall asleep cuddled up with him in my arms as he was dying. We were afraid it would trigger his final comfort. So they went out of their way to pull the bed cot up next to it. And then I said, well, he has to hold my hand. And so they had pillows propped up because I'm tactile. I knew I couldn't touch him again. So they had the pillows under my hand, and then they put his big hand on top of mine. And all night long, I just had that last hand holding. And it was like there was weave between us on a depth on the transcendent I can't even explain to you. And then in the morning, I could feel him shifting. I knew I could feel his energy changing. And I just pulled up and held him and whispered some last things in his ear. And he died in my arms. But, for years I couldn't date. It was a tough death. I had to process a lot. And I remember the first time I was with a guy and he went to slip his hand over mine. And it was the last person who'd done that was my husband. I just about lost it. But what they did for me to have that last tactile holding his hand, oh my God, I still want to kiss them for that. Because you forget even the gift of holding someone's hand and how amazing that feels because of the connection and the love and the commitment to each other, right? So, yeah, and then he said, and I last little words and goodbye in my arms, right? But that letting go is a very intimate moment all around. So the nurses were amazing. So
that to me is, I have... Joan Pham is another palliative nurse in Vancouver. She used to work at St. Paul's when I first met her, and she's at Richmond now and gets the honor of working with Aleco. And she made me this beautiful piece of art, and it's kind of a caricature of Florence Nightingale, and it says, "What would Flo do?" And, I often remember that. I often put that in my practice, and I do teach that to young nurses. It's like, what would Florence Nightingale do in this? And it may seem really archaic, but it's that it's the human connection, because I think that's what, for me, nursing is about. It's the human connection. I don't often say this out loud, but I'm a pretty skilled nurse. I've seen a lot of stuff, and so I can, normally I can say, oh, that's probably your kidneys. Oh, that's probably the liver. Oh, this is probably this cascade or that. I can do that, but where I really feel that the art of nursing is for me is in that that connection, right? That knowing. And, you know, this is another thing. Families always say to me, do you know how long I have? You know, because people still have lives to live, right? There's still work to go to. There's still this and dance recitals for grandchildren. And I always say I have the unfortunate knowledge sometimes of saying, I just think it's going to be 24 hours. I think it's going to be 48 hours. And I usually say to families, I hope I'm wrong. This is a time I hope I'm wrong. But sometimes it gives them parameters. And sometimes I am wrong. You know, sometimes it happens, that person lasts longer. But it gives them permission to stop their lives so they can be present. And that's the other piece that's really important, is giving someone permission to stop their life or their busyness so that they can remain in the moment with their loved one. The other thing I tell people is, sometimes people are hanging on. And, you may have told someone 100 times, it's okay to go, it's okay to go, it's fine to go, you can go, we'll be fine, whatever. And I always say that there's a point where you have to let go with your heart. Doesn't matter what you're processing in your head, but there is a point that if people are hanging on, I just say, you need to let go in your heart. And it's very difficult, but it's the greatest gift you'll ever give someone, is to let go in your heart. And that doesn't mean forgetting them or loving them less. It means that it's just this spiritual disconnect so that that person can disconnect. And it usually happens between like husbands and wives that are very close. And I have sat with people who have cried and said, I can't. And it's like, just sit with it. Don't try to be in your head about it. It has to be in your heart. The other thing that I'm really clear with caregivers is, this person will choose when they're going to leave. As we can't, Barb, I'm sort of in your metaphysical camp when it comes to death, because it's the same magic as birth for me. Death is the same magic. There's a term called kairos. It's Latin, and the translation is God's time, but I always say the universe's time. And we can't pick when we leave. We just can't. But, that person's going to choose when they leave. And sometimes if people have been really close with them, they can't go in front of them. It's just too painful. And so I always say to families, what you're doing by holding space is a miracle, and it is Herculean. And so you cannot hold on to the fact that somebody is choosing to go when you're asleep, because it happens so often. That family member, we had a young husband that slept at his wife's bedside day after day after day. And he put his head down on the bed and fell asleep for probably 15 minutes. And that's when his wife chose to take her last breath. And, you cannot have a regret about that.
Or that 10-minute cup of coffee.
Or going to the bathroom. It's
and
so
often
common.
When there's that deep bond, sometimes I say, you leave the room, it's easier to, we don't know all the dimension, but when
That's
there's
right.
that, if it was someone you love and they went to answer the phone, it might be easier to sneak out the back door when you weren't in the room, right?
100%. And, you just talked about, so I have been with a lot of people after they've passed. I've pronounced deaths. I've had the great honor of pronouncing someone, watching their last breath, and watching that spiritual piece end. But I always have this feeling that they're still with me. That they're still in the room. And so, I always teach young nurses is that our job is to, have respect, just keep continuing that life respect. Because they've done so many studies on near-death experiences, on people that are in comas, they know that people are still there. And so, there have been times when people have missed the last breath. Like I have been in the room when the last breath happens, but their loved one hasn't been. But I always tell them to come in and speak. Like keep that speak, because it's so important. And it's not just important to the person that's passed, but it's important for the person that's going to live forward. To know that, they have said what needs to be said from their heart, right?
Mhm. Well, so we're coming to the end, and you're touching in on that transcendent element that I always love to celebrate. Can you share one story around perhaps a deathbed vision or a dream? Because the nurses are often privy to that in profound ways that not all others. Can you share one story that you feel it's okay to share within confidentiality that touched you deeply in that realm in your time as a nurse?
So I had this is, I always, sometimes nurses always say, this is a crazy story, but because we all feel that, we witness it so often, it's sort of that disbelief. And I had this one person that came on and off. So the beauty of the unit is that because it manages palliative symptoms, often people would come in, get their symptom managed, and then go home. So they would come and go. So we had this one client or patient was in probably 3 or 4 times. So over that time, you get to develop quite a relationship with the people. They get to know you by name, you know them by name, you know their grandchildren, everybody, you know their story. This person was in a room where they could see the hallway. And I just had that feeling that this was it. This was the last admission. And so I was just sort of gently trying to prepare the family. And the patient's loved one was sitting at the bedside. And I walked by and they kept calling to me, Carolyn, Carolyn, come here, Carolyn, come here. And so I was like, okay, I went in and said, my bags are ready. And I said, oh, your bags are ready. And they said, yep, is everything ready? And I said, everything's ready. And they said, okay, because I'm going to go soon. And I said, okay, is everything ready? I said, yeah, everything's prepared. Don't worry, everything's prepared. And they said, okay, because I'm going to leave soon. And I said, okay. And their poor partner was very, very overwhelmed by the whole thing. And I kept saying, just it's okay. Like, it's okay. You'll be here. Things will be okay. And sure enough, that person passed that evening. And it was that, it was the security that everything was done. And, when I talk about that therapeutic relationship, that building of the therapeutic bond, what a relief to not have to give them a drug to make them feel better. What a relief to just have them trust me enough to say, for them to recognize me, call out my name, and then, be able to give them some peace of mind, plus their loved one. So the crazy part of the story is that pre-COVID, I used to do these little cruises sometimes just to get a break. So from here to LA or LA back, I have some friends in LA, I'd go visit them and then cruise home to Vancouver. So I was taking a cruise back and I always gave myself a massage. Like I'm a decadent princess, right? So it was like a little massage. So the masseuse had just asked me, like, what do you do for a living? And I'm always a little hesitant at first. I used to really be almost embarrassed by it because it elicited this very, oh, poor you. And it's like, not at all, because now I'm living really good quality life because of it. Anyways, I had just finished telling the story because this person had just passed. I was like, oh yeah, I'm a nurse, it's kind of nursing I do. And I just had this death that was really impactful to me, right? And, it makes me celebrate my time off and time with my family, blah, blah, blah. I come out of the masseuse room and there is the widow and their other family member. And I just start crying because I'm in this uber relaxed state. And they start crying because I had said to them, I'm going on this little cruise in my therapeutic chatter. So one of their daughters decided to take them on a therapeutic cruise. So there we are on the same therapeutic cruise for different angles. We're both bawling. And they say, can we have dinner tonight? And I said, for sure, we can have dinner tonight. So we had dinner and it was beautiful closure because it was sort of that full moment. And I always felt that, he maybe had a hand in that as well, right? So that's the best one I have.
Lovely, lovely. So if you could tell the audience, share with, and that is lovely, like just even the fact they were packing their bags and you all went on a cruise together in the end. So if you could share with the audience the gift of hospice palliative care, how would you explain that to them? Because just how do you want to express that as we come to
It's about that when you honor space, it doesn't always have to be sad. It can sometimes be a celebration. And when my friend died, and when I was really young at 21, I learned how to live a bigger life. And it's that whole idea of, celebrating and living the bigger life. And, for me, a bigger life is taking time to look at my flowers. I raise flowers just so I can look at them. I put out birdseed just so I can hear my birds. And living a bigger life doesn't mean doing outrageous things. It means being centered and present wherever you are every day. And, my loved ones that have gone before don't get that ability to do it anymore, but I do. And so I celebrate that. And I will always tell you I love you. I will always tell you, when I leave, I say I love you. I speak my mind. And I always give people a hug because we do not know how long we have.
Well, and my signature last question is always, how has your heart been changed by this work? And you've already touched in on the many gifts through what you've just shared. It's beautiful.
My heart is now even more on my sleeve, Barb, if that's possible.
Mm-hmm. Beautiful. Well, I just want to thank you. You are one of the most passionate palliative nurses I know, and I'm always deeply moved at how you hold respect for the dignity of life and honor the depth of the wishes and celebrate with the family, include them, so those last moments can be the most cherished and memorable. And you are, to me, a wonderful example of that. So I thank you for taking the time to come on, and I honor all the amazing work that you do, because it truly, in your own quiet way, is rippled out in service to others at such a profound and tender time. And we're all blessed because of that kind of dedication and commitment. So thank you.
Well, thanks, Barb. And thank you so much for asking me to do this. This was an amazing, amazing journey for me.
Lovely. Thanks again. Okay.